We are live, sir.
Good evening. Welcome to iFocus lecture 77. This is the second in the series of neuro-ophthalmology, and today we have Dr. Ambika, who heads neuro-ophthalmology at Sankara, Chennai, to speak to us on pupillary abnormalities. I hand you over to Rashmin Gandhi to introduce Dr. Ambika, and then she'll carry on with her lecture. Today also we are lucky to have Professor Pradeep Sharma chairing the session, and for expert comments, and Asha will be the moderator. Thank you so much. Rashmin?
Thank you so much, Santosh, and welcome to this second lecture of Neuro-ophthalmology module. It's my pleasant duty to introduce Dr. Ambika, who is currently the Director of Neuro-ophthalmology Services at Nethralaya. She's one of the best known neuro-ophthalmologists in India and has a lot of original and good work to her credit on papillary edema, LHON, and she's been doing a fantastic work at Nethralaya for many, many years. She's also a keen teacher and has been involved in quite a few conferences and academic symposia. So over to you, Ambika. She's going to talk to you about pupils.
Thank you, Rashmin, for the warm introduction. At this juncture, let me thank Dr. Santosh, Dr. Gandhi, and Professor Sharma for joining our sessions and this invitation. Is my screen visible?
Yes.
Okay, so I'm going to talk on approach to pupil disorders. So it's about pupils to pupils. So this is not something surprising for all of us in the day-to-day practice, where most of patients make the diagnosis and come only for a second opinion to us. But at least, thankfully, they have not yet made the diagnosis for their pupillary disorders. At least in my practice, I haven't seen as a second opinion for a pupillary disorder. So we should be thankful for pupils for allowing us to function independently, at least in this particular entity. So when we come to the pupillary assessment, what is the role of a pupil assessment concerned with the neuro-ophthalmology? The primary concern is to detect the optic nerve dysfunction. So whatever be it, any optic nerve dysfunction is going to have a pupillary abnormality. But it can also be seen in efferent disorders. So it is not only the afferent. So when you go for the pupillary assessment, what all you would look as things which you would note down as abnormal: the size of the pupil, shape, and the reflex. So what is the size abnormality called? It's nothing but Anisocoria, where it is not of equal size. If it is a pupillary abnormality which is affecting the shape, it usually has a past history of trauma, any drug use, or a surgery. And if it is going to be the reflex, it is nothing but the parasympathetic or the sympathetic nervous system dysfunction. If you come across any anisocoria, the primary thing for us is to check for any of these abnormalities of the parasympathetic or the sympathetic nervous system. So let me just revise the neuroanatomy. So the pupillary constriction do happen because of the sphincter pupillae, which is in turn controlled by the parasympathetic nervous system via the Edinger-Westphal nucleus and the oculomotor nerve. And the dilatation of the pupil happens because of the dilated pupillae, which is a sympathetic system from the hypothalamus, and it has 3 orders of neurons. So let me just go in detail about this, because knowing the pupillary right reflex and all these reflex pathways is very, very important for us to localize the level of the lesion in these disorders. So when you shine a light in one eye, the pupil fibers do traverse along with the visuomotor fibers up to almost the LGP. And at the level of the pretectal nuclei, there is the pupillary fibers which separate from the visuomotor fibers. And so they go to the pretectal nuclei, and the pretectal nuclei sends the signals to both the Edinger-Westphal nuclei. So when you shine a light in the right eye, the signals are going to traverse to both the Edinger-Westphal nuclei, and the stimuli from the Edinger-Westphal just reaches towards the pupillary fibers along the third nerve, and the action potential is generated from the Edinger-Westphal, and it goes to both right and the left third nerves causing both the pupils to constrict. So this is more important, and that's the reason why you get a consensual response in the fellow eye when you shine light in one eye. And coming to the pupillary near reflex pathway, we all know as the pupillary fibers traverse and the visuomotor fibers do reach the cortex. So the signals from the occipital cortex, both the parastriate and the striate cortex do generate the signal, and they do go to the signal via the occipito-mesencephalic tract. They stimulate the pontine center, and then from there to the midbrain, where it stimulates the nucleus of medial rectus and the fibers, and the signal passes through the third nerve to cause the medial rectus to act, which in turn causes the eye to adduct. And at the same time, there is something which is happening because of the adduction. There's a signal which traverses to the midbrain, stimulates the mesencephalic nucleus of the book nerve as well as the convergence center, which autonomously gives the signal to the accessory ganglion and the ciliary ganglion. And the signal causes the sphincter pupillae to function, and there is a pupillary constriction. So both the convergence and the near reflex do happen along with when there is a near target. So coming to the sympathetic pathway, we all know that there is three levels of three orders of neurons. Starting from the occipital cortex, the signal comes to the hypothalamus. From there, it traverses along the brainstem and comes to the almost C8 to T2 of the lateral spinal cord. From there, the second order traverses along over the apex of the lung, and then it goes to the internal, the superior cervical ganglion and the internal carotid artery and the carotid-cavernous plexus around the cavernous sinus. It goes to the cavernous sinus, and then it goes to the dilator pupillae, which causes the dilatation of the pupil. So there's almost, this is the first degree, the first order, the second order traverses over here, and the third order reaches up to the dilator pupil. So the lesion can be in any of these three order pathways, which can affect the sympathetic system and cause a defect in the dilatation of the pupil. So are there anyone who is participating, Rashmin, any postgraduates who can answer these questions? So the most important key in neuro-ophthalmology is history taking. So how do a patient who has a pupillary abnormality present to an ophthalmologist? Do we have anybody who's participating? Dr. Rashmin? Yes, is there any postgraduates who can answer that?
Ma'am, I'm not sure of the hot seats today.
Okay, so we'll move on. So any patient who has got a pupillary dysfunction can present with conditions like a glare or light intolerance. They can come with a hazy vision and a near vision difficulty and difficulty in depth perception. So these cannot be that frequently seen when the condition is going to be monocular. So if there is a bilateral pupillary disorder, then probably the patient can come up with these symptoms. So in other words, you have to always check the pupil with the associated symptoms. So these are the commonly associated symptoms with the pupillary disorder, like a headache, vision loss, a squint, double vision, ptosis, and reading difficulties. These are quite common associated symptoms in a condition of pupillary disorder. So again, coming to the clinical examination, we are not, we will not be surprised to see this abbreviation in most of the med school records. So what do you mean by PERRLA? So which means pupil is equal, round, reacting to light and accommodation. So always check the pupil size both in bright light as well as dim light, and then move on to the shape and the position of the pupil. So there could be a normal circular shape, or there could be a correctopia or a polychronia. Always watch for these conditions because they're going to give us an add-on clue that what type of pupillary abnormality we are dealing with. So coming to the reflexes, it can be a direct reflex and a consensual reflex. Both has to be checked. And check whether the speed of reaction is normal. Is it brisk? or sluggish? And is it well sustained or ill sustained? After checking the direct light reflex, we are going to always do for the near reflex assessment too. So these are some structural iris abnormalities and shape irregularities which can be presenting to us. So always we have to be careful in finding what is the cause for these sort of abnormalities. So it could be a Western pupil, surgical iridectomy, and it could, this was a chronic angle closure glaucoma with a iridectomy, and this is an iris coloboma. This is a D-shaped pupil following a trauma where there's a iridodialysis, and this is an adherent leucoma which is causing a shape irregularity. So the gold standard of swinging flashlight test to test for a relative afferent pupillary defect. This is called Marcus gun pupil. This is the hallmark of an optic pathway afferent dysfunction. So what do you need? You just need one normal pupil to check for a relative afferent defect. And obviously you're checking both the eyes. So this is a relative condition. So you're going to say a relative afferent pupillary defect can be there only in one eye. Okay. So there cannot be a relative afferent defect in any lesion that is above the LGB or any lesions which are pre-retinal. So these are the way places where you can have a lesion and don't have an RAPD. So what are the requirements for a relative afferent pupillary defect checking? So what are the criteria? You should have a dark room. You should need a bright point source of light, a distant fixation target, and as I mentioned, a one normal working pupil. So testing for the relative afferent pupil defect, when you shine the light in one eye, you can get a relative afferent defect in one eye. If it is going to be a monocular visual afferent pathway dysfunction. If you encounter a bilateral afferent pathway dysfunction, obviously you will not get a relative afferent pupillary defect, and you're going to end up seeing a bilateral sluggish reacting pupil. So this is one thing which you have to be careful when you're mentioning about the relative afferent pupillary defect. So as I mentioned, when you shine light, you see a constriction happening in one side. And if you shine the light and you don't see a constriction both in the light, in the eye where you put the light and at the fellow eye because of the absence of consensual, you would call this instead of constriction when it dilates, it's the relative afferent pupillary defect. So we will see a video.
Ambika, there are two people, Dr. Soni and Dr. Arnav. They are on seat. There are two postgraduates, Dr. Sohni and Dr. Arnav.
So let me see a video demonstration of a relative afferent pupillary defect. When you shine the light here, you don't see a immediate constriction. Rather than that, you're seeing a brisk dilatation with the initial constriction. There's a very fast, greater redilatation of the pupil. And you see the same in the fellow eye, a brisk constriction. So it was a right-sided relative afferent pupillary defect. So coming to the grading, as I mentioned, it could be grade 1 to 5, but anything beyond grade 3, it almost overlaps each other, the stages. So the initial weak constriction with a greater redilatation is grade 1. And grade 2 is an initial stall with a greater redilatation. And grade 3 is immediate dilation, as you saw in this patient. And grade 4 is an immediate pupil dilation following a prolonged illumination of the better eye. And grade 5 is an immediate dilation with no secondary constriction. So these are the 5 grades of a relative afferent pupillary defect. So what do you see in this picture? What is this? Any of the postgraduates whom Dr. Gandhi had mentioned?
Yeah, Dr. Arnav, Dr. Soni, one of you.
What do you see in this picture? Have you seen this gadget?
The numbers might give you a clue. It's 0.3, 0.6, 0.9, and 1.2.
And I just spoke about RAPD. Okay. These are neutral density filters. These are used to quantify the relative afferent pupillary defect. And how do you do this? You just put it in the wireframe, just continue to assessing the relative afferent defect at the point log units where the RAPD disappears. You quantify that as zero 0.6 or 0.9 density of relative afferent defect. So this is a very important exam question, what you will be asked. And in case of a unilateral optic neuropathy, always remember the severity of the RAPD is proportionate to the severity of the vision loss. But there can be conditions where you may not have an optic neuropathy. You will still have a relative afferent defect like a dense amblyopia or a significant maculopathy, which causes a profound visual loss. And an amaurotic pupil is a condition where there is an absolutely no reaction to light. So how do you check if you're going to have only one pupil? For example, you're going to have a sphincter damage or a corneal opacity in one eye, and you're going to have only one functional eye where you can see the pupil. How do you proceed in such condition? Fine. That's the condition which will be using a reverse RAPD assessment. Here, you're going to shine the light in the normal looking functional pupil. So when you shine the light in this only functioning pupil, you would see a normal constriction happening over here. And the fellow eye, you're not able to see the pupil. Maybe it can be having a dense corneal opacity, or you're not able to visualize that. So you could not see the pupillary response. So when you shine the light in this functioning normal pupil, usually there can be a consensual response which constricts this pupil. So you're not able to see this left eye. So when you shine the light in the left no pupillary response eye, you still continue to look at the eye which has the functioning pupil. So again, when you shine the light over here, you should expect to see a constriction due to the consensual response of the fellow eye, which does not happen. So if you see a slightly dilated pupil, when you shine the light in the non-seen pupil eye, you would call it as a reverse relative afferent defect, which says that this pathway is dysfunction. So you need only one working pupil, as I said, to check for a relative afferent defect. So the next question is, can you have yeah, it's visible. So can you have a normal vision and a normal fields in both the eyes and still have a relative afferent pupillary defect? Anybody? Dr. Soni?
Yeah, Dr. Arnav.
Arnav is also there.
Dr. Arnav?
Internet issues, if it's sorted, that's a question. If you have normal vision and fields in both the eyes, can you still have RAPD in one of the eyes?
Okay. Yes, it's possible. So the condition is called a tectal RAPD, where you can have a lesion at this level where the pretectal nuclei, the small interconnecting neurons are giving the command to the erinaceous nuclei. See, before this, the visuomotor fibers, you remember the anatomy, the visuomotor fibers have separated. So that carries the normal vision and the normal fields along with them. And here, where you have the signals coming from the pretectal to the erinaceous, if you have a lesion over here, you can have an absolutely 6-6 vision, the normal fields, but still you could end up having a relative afferent defect in one eye. So that's called a tectal relative afferent defect. So if it's going to be what are the conditions where you can see a normal vision with an abnormal pupil, like what I had asked now. So what are the conditions where you can come across such a situation? So this is the list of causes where you can have a abnormal pupil, but a normal vision. So all these conditions do affect the pupillary pathway in one way, either directly or a structural change, which results in an abnormality of the pupil. So these, as I said, you will be seeing all these disorders shortly. And I think you all are aware that cerebral palsy can cause a defect in the motility. So it may or may not be having a vision dysfunction. And it can botulism, trauma, and all these things can cause local structural changes of the pupil, but still can have a normal vision. So we will move on to the evaluation of anisocoria. See, this is anything, a pupil inter-eye difference of more than 2 millimeter, you call it a pathological condition called anisocoria. But we should remember that there is a possibility of having a 20% physiological anisocoria also. So always when you start evaluating, watch for the family albums. You will see these red reflexes in most of the kids, particularly in the kids. I prefer to do this PAT scan when I see for the anisocoria. So start watching, because we don't have, unfortunately, an iris color like this in our Indian population. We end up having an iris color like this, where you have to really figure out where the pupil is in those photographs. So always use this red reflexes at times, because you can see the difference in the reflex size. Okay, so
I think someone else is also unmuted the video. Can someone please mute the video?
so there can be an associated squint and lid abnormalities. Always ask for history of any drugs intake. Ask for the history of the profession, what they belong to, because all can have a association to the pupillary dysfunction or the disorder what you are seeing in that patient. So ask for the history of, because sometimes people will have the scopolamine patch post-surgical and all those. So just ask for them, do they have any of those patches which are being used? And coming to the profession, there are some, like we are a country which is predominantly having agriculture and farming. And particularly, this is one condition which at least a couple of times I have encountered, where a farmer who is working predominantly in the corn fields do have an exposure to this particular weed, which if accidentally falls in the eye can cause a abnormal dilatation of the pupil. And in fact, it's been described in the textbooks as a corn pupil's pupil. So watch and always ask for the profession of the patient, because sometimes it can give you a clue for an accidental, involvement of any pharmacological dilatation or a weed, something like this, which could have fallen in the eye. So when you come to anisocoria, always check for whether it's more in light or more in dark. So if it's going to be an anisocoria more in dark, then it is the dilator pupillae and the sympathetic system which is at defect. If it is going to be an anisocoria that is more in light, it is the sphincter pupillae, which is the parasympathetic innervation, which is at fault. So based on this, we would evaluate an anisocoria. And even though when you look at that, one important factor is always do check for a light near dissociation. Because what do you mean by a light near dissociation? Here, the pupil light reaction is poor. So when you shine the light on the pupil, it may not react. But when you give a near target, the pupil can constrict and it can react. So when there is a light reaction which is impaired, always check for the near reaction. If you see a light near dissociation, it can be one of these three causes: a tonic pupil, a Afferent syndrome, or an AR pupil. If there is no light near dissociation, or LND, what we call, it could be one of this: a third cranial nerve palsy, a structural change due to one of this uveitic or glaucomatous entity, or an anxiety pupil. And it could be a drugs associated. So this is quite complicated, it looks, but it's quite easy. And this is the most common algorithm what we use in our day-to-day practice. So if you see an anisocoria, which is more in light, always next step, check for the extraocular motility. Check for the presence of the ptosis. If the extraocular motility is abnormal, if there is a ptosis, it could be a third cranial nerve palsy. If the extraocular motility is normal, then watch for the slit lamp examination. Do a detailed anterior segment examination watch for signs of uveitis, glaucoma, ask for any history of surgery. So this is going to give the clue if it is going to be a structural disorder. If the slit lamp examination of the anterior segment is normal, then move on to do the near reflex assessment. If you see a near reflex assessment, if you see a tonic pupil, what do you mean by a tonic pupil? Which means it just has a constricted appearance. It doesn't dilate again. So that's the classical, it's almost like a mid-dilated position. So that's classical Aries tonic pupil. So you would use a 110 pyrocarbon to confirm a Aries tonic pupil. If it is going to be a near reaction is going to be normal, then it could have been a pharmacological dilatation. So which you can confirm by using a slightly higher dose of 1% pilocarpine and see for the constriction. And if it is an acute Aries tonic pupil, sometimes you should remember that if the patient has developed an Aries pupil within a week, even a day, or to somewhere 1 or 2 weeks, they may not have the classical response to the pilocarpine test. So you just wait for the denervation supersensitivity to kick in. So when you see an anisocoria, which is more in dark, it could be a Cavernous syndrome. So cocaine testing, I think we will just move on to these pharmacological tests as I go with these disorders in detail. So you can differentiate a Horner's from a physiological anisocoria. So you have either you see whether there is a Horner's or not, or next is you localize where the level of lesion is. So this is the algorithm which is being practiced for a evaluation of anisocoria. So now we will go one by one. So we are going to go to anisocoria more in light. As I mentioned, tonic pupil or the classical Holmes ID pupil will have a poor pupillary light reaction because of the segmental palsies of the sphincter. So there can be a pupillary area which can be segmentally normal and segmentally having palsy. So that is the reason why the pupil can behave a tonic. So the near response, there will be a good near response. And there can be a cholinergic supersensitivity, and there could be an accommodation paresis, but mostly it tends to recover. And there can be an induced astigmatism to near, and it is because of the prolonged, near work, it could also go on for a ciliary muscle cramp. So this is what a tonic pupil would look like. This is in room light. When you shine a light in this eye, you see the normal pupillary constriction is not happening. So the fellow eye is constricted, but this eye remains big. So pupil remains big. So this is a poor direct response of an Aries pupil. So here you're shining the light in the fellow eye, and you see a poor consensual response in this eye. So again, showing that it is not reacting to a light. But see, the same eye, when you give a near target, it started constricting. So there is a poor light reflex and there is a good near response, which is a classical phenomenon of an Aries tonic pupil. So when it is along with a component, like you will have an exaggerated deep tendon reflexes, we would call it as an Aries syndrome, which usually happens in females. And anyone 30 plus, almost in say third to fourth decades, you can see. And most of the time, 80% it's uniocular, but we have seen patients coming with bilateral Aries also. But it could be a sectoral palsy, and as I had mentioned, it is quite rare to see a bilateral Aries. And what you do is a diluted pilocarpine. Why do you use it in a diluted concentration? Because here there is a supersensitivity because of the denervation. So even at the lesser concentration where a normal pupil will not constrict, a Aries pupil will constrict, but always wait for a while, wait for a few weeks for you to see for this response on a pilocarpine test. So sometimes this initial mid-dilated tonic stage can, as weeks goes on, or even sometimes I have seen patients who are like quite almost they remain tonic for few years also. In the later stages, it turns out to be a what we call as a small pupil, little old AD. In this condition, you may not see that response what you see in the acute phase. So in the early phases, it can be a tonic, mid-dilated pupil, but later stages, it can become a small pupil, almost like an AR pupil. So Argyll Robertson pupil, as the name stands, there is an accommodation reflex which is present, but the pupillary reflex is absent. So this AR pupil is usually small and irregular. It could be a variable iris atrophy. It can have a normal visual function. There can be an LND, because if you see a AR pupil, the first thing to check is the syphilis. So the tertiary syphilis, this is the hallmark of a tertiary syphilis. So here what happens is the lesion in the rostrum membrane and pretectal nuclei. There could be a involvement of the dorsal side of the adingal westphal nuclei, sparing the ventral side, and that's the reason why you still preserve the LND. And as I mentioned, it is quite common in neurosyphilis, but there are other causes also which cause a AR pupil, like chronic alcoholism, encephalitis, multiple sclerosis, degenerative CNS conditions, and even a neurosarcoid. And in fact, we should also add neurocysticercosis, because I end up seeing a case of neurocysty who presented with a AR pupil. So a pseudo AR pupil is another entity which again can happen when there is a normal near reflex and absent light reflex. There will not be a meiosis like an AR pupil, and the pupil will be irregular again. It could be slightly bigger than the pseudo AR, than the ARP. Again, these conditions can cause a pseudo AR pupil. And most of the time, pseudo AR pupil is associated with a membrane lesion causing a Pharmacological syndrome. So here you have the other features like paralysis of the up gaze, preserved down gaze. You will have an intact doll set. And as I said, the pseudo AR pupil, there could be a convergence retraction nystagmus, where on attempted upward gaze, it can produce where there could be a faster eye being tucked in and the globes retract inside. And there could be a Collier's sign where you have a eyelid retraction. And you can also see a conjugate down gaze where the preserved down gaze causes always a sunset type of appearance of the eyes. So this is the triad of the Pharmacological syndrome. So now we will move on to the Anisocoria more in dark. So as I mentioned, if it is going to be a more in dark, it's, remember this person who showed us this hallmark photograph of a Horner's syndrome, where you could see a ptosis, a meiosis, and you can also see the other features of the Horner's syndrome. You can see an upside down ptosis, and it is anisocoria due to ipsilateral meiosis. So here, this is the abnormal eye. See, always in anisocoria, you will get a confusion that which pupil is the abnormal one, the smaller pupil or the bigger pupil. So always watch for the other sides before making the diagnosis. So if you see a anisocoria which is more in dark with a droop like this, definitely honors to be the top differentials for you. And there can be a dilation lag. So because of the sympathetic dysfunction, it doesn't dilate that easily. There will be a slow dilatation of the pupil in the darkness. And there can be an increased accommodative amplitude. And sometimes it could be an ocular hypotony and a conjunctival hyperemia. And there can be a facial anhidrosis when it starts involving the other segments. Rarely we see all the other features like stromal edema and all. And heterochromia is not that commonly seen, at least in the part of the India where I practice. So pharmacological test, yes, these all are like exam oriented. But when we really practice in our day-to-day, I don't think we all do this direct, indirect, and I don't think we get access to cocaine and all these drugs to do these pharmacological, but definitely you have to know them for the exam purposes. So these tests can be categorically separated as indirect or direct assessment. Here, first we put the cocaine to find out whether there is a lesion or not. If it is going to be a Horner's, it doesn't dilate because of the knockoff of the sympathetic pathway. Only the normal ones do dilate. If you want to localize the lesion, whether it's preganglionic, the 1 and 2 order or the 3rd order, we can use a second test of amphetamine, where you can use only the 3rd order ones, where it doesn't, there's no dilatation, sympathetic activity. That shows that it is a postganglionic because there's hardly a epinephrine which is available for that to dilate. If it's going to be a preganglionic lesion where it could be the 1st or the 2nd order neurons involvement, here there is either the norepinephrine reuptake is stopped, or they are stimulating the norepinephrine. So which can cause the eye to dilate. So this is the indirect group of assessment. And if you directly put an acroclonidine in the Horner's eye, if it dilates, because generally in that concentration, a normal eye will not dilate. So that's the spot diagnosis for you to make a diagnosis of Horner's because of the denervation supersensitivity, the acroclonidine to accept. To be honest, I don't do any of these pharmacological assessments. If I see a Horner's, I do stat imaging of an MRI plus MRA of the head and neck. So you're going to screen right from the hypothalamus to the lateral spinal cord, to the apex of the lung, to the neck, to the internal carotid artery, to the cavernous sinus. So you need to do a MRI with an MRA head and neck and find out the lesion which is causing the Horner's. In an acute setting, if you see a patient who is walking in with a headache or acute onset Horner's, be very careful. It could be a carotid dissection too. So in an emergency situation, you can also ask for a CTA to confirm the diagnosis. So these pharmacological assessment, as I mentioned, it's not that easily available to us. So to complete, I'm adding few pupils in not responsive comatose patients, a tectal pupil. A pontine lesion can cause a pinpoint pupil. A midbrain, again, as I had discussed, can cause a fixed mid-dilated pupil. And a third nerve cranial palsy with a fixed dilated pupil in the fellow eye due to uncal herniation, and a diencephalic pupil can have a small but reactive pupil. These are few pupils which can be seen in non-responsive patients not comatose. So this is a patient who had a midbrain lesion. I'm going to show a tectal pupil. You can see the pupil. So here you're able to see the constriction to certain extent on her attempted near, but when she sees with a distance, like they move on to have a dilated appearance. So that was a tectal pupil. So these are few interesting pupil names. For completion, again, the Hutchinson pupil, where I said that the dilated pupil due to ipsilateral third nerve compression, most commonly it is associated with a space-occupied lesion. A vernix hemianopic pupil, where if you put the light on the one half of the retina, there could be a constriction of the pupil, and Bird's pupil is at the larger pupil at the site of a cerebrovascular accident. So let me go through a few cases. How do these patients do present to us? So this is a 68-year-old female who was brought to me with a history of headache for 1 week. She had a droop and a diplopia. So is there any postgraduate who can add what all you see in this?
Dr. Shoni and Dr. Arnav. So either of you can answer what you can see in this case.
What do you see in this? I had mentioned that the patient came with the complaints of ptosis and a double vision. So what do you see in this photograph?
Dr. Arnav, is your internet connection okay now?
Okay. So we see a primary gaze lid droop. There is a ptosis. You can see visibly the left eye is moving, the right eye is not following. So there's a restricted adduction, impaired depression, abduction is full, and there is a restricted elevation. So there is a ptosis with a restricted adduction, depression, elevation, nothing but a palsy. But surprisingly, the pupil, you could see here that pupil is small and reacting to light. So there is a pupil sparing right third palsy in a 68-year female who has a poor control of diabetes and hypertension. And surprisingly, she had a history of ventriculoperitoneal shunt 8 months back for intracranial bleed with an hydrocephalus. So this was the history what I saw. So this is the MRI, which is showing you ischemic periventricular changes. You can see the shunt tube in place and functioning. So I said, okay, I always have the habit, if I see a pupil sparing third nerve, I always call them if they are a localite for a 2 weeks follow-up with their blood parameters evaluated. So when I called her for the blood workup, her HB1AC, you can see visibly she's a poorly controlled diabetic with dyslipidemia. Surprisingly, when I rechecked her pupil, the pupil became dilated. So a pupil sparing, which was 2 weeks, just 2 weeks back, became pupil involving. So I said, like, okay, now we can't wait, we move on, repeat the MRA, and we picked a small PCOM aneurysm, which is sitting close to the right. This is the DSA which picked the PCOM aneurysm. So what I say is, in spite of having a vascular risk factors, which can give an explanation to the pupil sparing third nerve, very rarely you can see a pupil sparing evolved into a pupil involving third nerve. But it's not an exception. So that's the reason why I brought this case up. So that's a right PCOM aneurysm causing a pupil evolving right third nerve. So this is the second female who came to us with complaints of sudden drop in vision. And incidentally, when we evaluated, she also had a droop. She had a completely normal extraocular motility. There was no diplopia. And when I saw first time, my fellow had already dilated the patient. So the fundus was normal, vision was slightly down, fields was normal, and the MRI was normal. So when I spoke to her, she said, "Doctor, I just came for my vision problem. Don't worry, I have a droop in my eye, but my MRI brain is normal. And probably it would have been earlier, I did not notice because I'm not having double vision." So she's a quite smart patient. She said, "I don't have diplopia. My MRI is normal. So you don't worry. You just explain why I'm having this vision problem in the right eye." So I said, like, see, we are dealing with two conditions and I want to see you again undilated. Probably, can you please come back again for a pupillary examination? I called her. So this is what I saw her maybe a week later. You could see there is a lid droop in the right eye, which eye the vision is down. There is a meiosis and the fellow eye is normal and the pupil is slightly large. So this is an Anisocoria that is more in dark. So I said, like, sorry, I think you have to be evaluated. This is something which you have to take care. And MRI brain is not the only investigation what you need. I think you have to screen the second and the third order. And can you imagine this is the lesion which we put in her in the neck. So there was a huge vagal schwannoma which was sitting very close to the internal carotid artery cavernous plexus, causing the right honest pupil. So now we got the answer for her lid droop. But still we have one more question which is unanswered, that cause for the vision loss. So I asked for a Hertford dot and surprisingly it turned out to be a microtropia which this lady started noticing after her right lid droop. So that was a right side honors with a microtropia. So this is a 37-year-old general surgeon whom I saw. He came with a sudden onset lid droop in his left eye. He also mentioned, "Madam, I did MRI, everything normal, but still I'm having pupillary disorder, and I think it's a pupil involving left third nerve. And in fact, I have more difficulty when I look down," he said. See, in a pupil with an extraocular motility disorder, where you are thinking that it could be a cranial nerve palsy 3, always watch, is there any other cranial nerves which are involved? Is it an isolated third nerve or is there any coexisting other cranial nerves which are involved? So this patient, he's on hypertensive on medications and he did not have any other systemic disorders, but he had a short course of oral steroids as recommended by his previous ophthalmologist, but still he did not recover. So he said, I'm finding it very difficult. I could not operate in my theater. Please do something. So we went back in his MRI and we reassessed his MRI. And this is what we came up with. So there was a subtle enhancement in his left side cavernous sinus, and there was an ill-defined soft tissue lesion. This is an axial MR T1 flare images, which are showing that there is a high intensity lesion which is close to the left cavernous sinus. So we did all his general evaluation. He had cervical nodes, and surprisingly, he reminded us before making the diagnosis of TB, you should not move on. So this guy had an elevated ESR, a MAN2 and a quantiferon positive. And in fact, we went ahead and did a scaly node biopsy. It showed the necrotizing granulomatous adenitis, and his chest had multiple nodes also. So this was a granulomatous inflammation of the left cavernous sinus, which had caused probably, to begin with, he would have also had a fourth nerve, which could have affected his double vision more on down gaze. And with the subtle course of steroids, he would have responded. And subsequently, his chest and MRI brain and chest all showed signs of resolution. So there was no enhancement of the third nerve. There was a reduced lymph nodes also on his follow-up. After the antituberculous treatment, he had a complete recovery of the third nerve as well as the fourth. Probably he would have had a third and fourth because of the left cavernous sinus lesion. So to conclusion, I'm adding this entirety. There's something called pupillography, where that's a method of recording and measuring the reactions of the pupil, where we can use an infrared video camera and a computer software to analyze the images. We use it in conditions where there is the pre-verbal or non-verbal children or even patients. And it can record the dilation lag, the pharmacological effects, and to a certain extent, it can also measure the RAPD. Of late, it is mostly used only in research setting. I just added this for completion that such a condition is existing. So quickly, I'll give you 2-3 questions. Again, if there are any postgraduates who are interested in joining, you can answer this. So in this, I'm shining the light in the right eye. What do you see? There's an absent light response when I do. And this is a condition where I have done a pirocarpine test. So this is pre-pirocarpine, this is post-pirocarpine. This is a case of Holmes adipute. And this is a guy who came after a hemithyroidectomy surgery. He developed a droop. So that was his complaint. He had normal vision, no diplopia. He developed this droop after his thyroid surgery. So this is a right corners. There's a meiosis, which you could see visibly. There is a lid droop, meiosis. This is a right corners post-thyroid surgery. And this is again, is there anybody who can answer this? What do you see in this photograph? This is the last.
I think it's too complicated for our PhD and to understand. They haven't even. I don't know whether the net is off or the.
Okay, this is a right third nerve palsy. You can see a pupil involving third nerve. In fact, this guy had a herpes zoster recently. You can see the scars. That's what this air mark is pointing. So he has a right third nerve, sixth nerve, as well as a fifth nerve palsy. And this is a multiple cranial nerve palsy post-herpes zoster infection. And these are the serial axial cuts of the MRI flare, showing a diffuse enhancement of the right optic nerve. You can see it almost entering up to the apex. You can see there is a ill-defined soft tissue lesion at the right cavernous sinus. And in fact, there is a lesion also at the level of the lateral medulla and pons involving the fifth nerve. So this is a case of right herpes zoster ophthalmicus causing a multiple cranial nerve palsy, which is causing even a pupil involving right third nerve palsy. So to conclude, pupillary examination is the hallmark of optic nerve function test. But acquired anisocoria, you be very careful in the analysis, because sometimes you can also have a physiological anisocoria, which the patient comes up suddenly with. Pupillary abnormalities can be with normal vision also. It is not that you will always have an abnormal vision when you see an abnormal pupil. And in a non-responsive patient, they do play a vital clue in localizing the level of the defect. And pupil searing, partial third nerve palsy, you have to always image, because sometimes, you have to always follow up, because that pupil sparing can eventually become pupil involving at times. So keep your patients in close follow-up when you see a partial third nerve. If it's a complete third nerve with pupil sparing, probably you can relax. So if the eye is the window to the brain, then you can say the pupil is the peephole. Thank you. Thank you for listening.
Yeah, thank you so much, ma'am. The class was really wonderful. We didn't have the hot seats answering, but we had few questions from many of us. I'm just putting across the questions. So there is this question from Dr. Abhishek. Can RAPD be demonstrated if other eye is PL negative, and how?
Yeah. So as I said, no, you need only one working pupil. Okay. If the fellow eye is an amerotic pupil, you cannot see that, you cannot use that pupil. So eventually you are not able to. So you're saying that you're not having this pupil, so you can't use that pupil at all. So you're having only one functioning pupil. So you shine the light over here, see if the pupil is reacting. And if you go back to the eye where you don't use the pupil, you shine the light over there, and you still see a slightly mid-dilated pupil in the normal functioning pupil, which means that there is a reverse RAPD in the eye, where the consensual is lost because of the pupillary dysfunction.
Yeah, I hope he got his answer. Ma'am, there is another question. How can pilocarpine act on pharmacologically dilated pupil?
See, it depends on the concentration what you use. In a pharmacologically dilated pupil, you have to increase the concentration. Maybe beyond 1 or 2 might react at times. But it depends on the concentration. If it is going to be ADs, it's well and good, because it's going to be a super sensitive pupil which can react even to the lowest dilution.
Okay. What is the difference between grade 4 and grade 5 RAPD?
Anything beyond 3, I don't count it.
Okay. So the neutral density filter, is there some other way to represent that? I think they're asking about the bar. Do they have it as well?
Yeah, you have it, but I mean, like, we have not used that. Probably Professor Pradeep Sharma, do you use it in RP Center?
For the
neutral density
bar,
filters.
the neutral density filter bar we do have at RP Center, but we hardly use it for this purpose.
Exactly.
Mostly you can have the qualitative assessment by other means, but yes,
most of the time we use it as a teaching tool, because in the day-to-day practice, as I said, anything grade 3 plus, I don't count, it's 4 or 5.
But if you want to do an academic work, then you can do that.
Yeah, you can.
And also you can do like the pupil cycle time. There's another academic thing which you can do, measurement of the pupil cycle time. For 50 cycles, you can measure the time. That will also tell you and quantify how much is the involvement of the pupil.
Thank you, sir. So, ma'am, there is another question for you. How do you diagnose a tectal pupil?
So should I go back to my screen? Is it visible?
Yes, ma'am.
Okay. So this is what I said as tectal pupil, where you will have a lesion at this level, the pretectal. See here, you are going to have the visuomotor fibers have traversed. Only the pupillary fibers are entering the pretectal nuclei. So the pretectal nuclei is going to give the command to the Edinger-Westphal nucleus of both the sides, to the right and the left side. So if you have a lesion where involving the internal, the interconnecting neurons from the pretectal to the adengovespal, you will have a condition where you will have a relative afferent defect, but you will have a preserved visual function. So this entity is called tactile RAPD.
So there is this question: how frequent do we see tactile pupils? Is it like common?
See, if you come across any space occupying lesion or any, I mean, like CNS lesions like demyelination, degeneration, or it could have been a neurocysty or any inflammatory disorders involving that particular tactile area, which is too focal, probably you can end up seeing a tactile pupil. Like we see it quite common after any midbrain lesions, either pre-surgery or even post-surgery. Sometimes patients can come up with a tactile pupil.
Ma'am, there is this question. I think it's what you have mentioned. Scopolamine patch the history has to be taken in Anisocoria patients. So how does scopolamine patch cause anisocoria, lateral pupil involvement?
It causes an effect like a sympathomimetic. So it's going to make the pupil dilate. Okay, so sometimes they can have the patch as a long-standing, like it could be a long-standing what we call as a release phenomenon which happens in the body, which can act in the sympathetic fibers and cause the pupil to dilate. So always look, because most of the time they may have it on the neck. That's what I have seen few patients coming up with. So that is a sympathomimetic drug. So watch for it if you see a dilated.
I think the question is, why is it unilateral? Like if it is a patch.
I have seen it. It might be a asymmetric involvement. It can be I mean, relative change is what I feel. So I haven't seen only a one eye dilated pupil. I see both the pupils slightly, what to say, not normal. It can be a mid dilated where it could be asymmetric.
Okay. And there are few questions on Aries pupil, like why are we supposed to wait for few weeks in Aries pupil?
See, in Aries pupil, the pupil is going to be a mid-dilated one. So you are trying to prove that it is a denervation which has caused a supersensitivity. For the denervation to show its response, it usually takes some time. And if you do it in an acute AD, say the guy developed an AD just a day or two back, or even a week back, the diluted pilocarpine may not show a response in such acute condition. It usually takes few days to develop. So that is because for the denervation to kick in and to respond to the extremely diluted pilocarpine.
Yes, ma'am. Would you like to add anything, sir?
I think it's been a very wonderful class on pupils. And as it is to be said in more general terms, I would say a teacher is good if he knows his pupils. A neuro-ophthalmologist is good if he knows about pupils. Pupils is the one thing which will clinch you as a neuro-ophthalmologist, because most of the time, many of the ophthalmologists just straight away dilate the pupils and send us to neuro-ophthalmology for examination, and we lose the basic thing that is most important. As Madam has highlighted, your pupillary examination can easily differentiate if there's an optic nerve problem or a macular problem. Both may be causing vision loss, but the clincher is the pupil. So the pupil is one of the most important things. One should know about it to analyze that. Madam has very nicely highlighted the pupillary involvements which may be related to the lack of dilatation or lack of constriction. So in two types there can be, and she mentioned that one which is more in dark and more in light. So the anisocoria can be differentiated in that manner. Basically, they are the problems which are because of the constrictor or because of the dilator pathways. So I think that part has to be kept in mind when we are analyzing the pupillary abnormalities. There are certain things which I would maybe like to add one that something what is known as somebody asked that what about if one eye is having no vision at all? the word RAPD would not be correct to be used in that sense. We are generally saying if suppose there is a total afferent defect, then we say it's an absolute APD. It's not a relative afferent pupillary defect. Relative always means when there is a difference between the two eyes, and that's why we use the term RAPD. If there is an optic nerve PL negative in one eye, we will say that there is a total absolute afferent pupillary defect in that eye. But if you have to observe for the other eye, yes, you can still see the involvement of the other eye by seeing the pupillary reaction. So one thing is that you have to see that the consensual is there or not. Second is what is the speed with which it is reacting. And this is also one of the important points when you have a bilateral involvement. So there may be a toxic optic neuropathy, or it may be a hereditary optic neuropathy in which both the optic nerves are involved. What you are going to see is not an RAPD because both are equally involved, but you will see the speed with which the reaction is occurring. So that is another point which you have to take in your examination. Third thing I would like to say is that for examination of the pupils, many times it is not highlighted in the books, but what I find most useful is the direct ophthalmoscope. Use the direct ophthalmoscope in the retroillumination mode. You shine the light, and when you are doing the swinging flashlight test with the ophthalmoscope, you will be able to pick up even minor RAPD changes which will be missed on the torchlight examination. Because when you see against a red glow, you will be able to pick up this minor RAPD also if you use the direct ophthalmoscope as a swinging flashlight test. So that is something which I would like to say that one should be always remembering. Another thing which may be also read by the postgraduates is the paradoxic pupillary reaction. So some conditions like the CSNB, congenital stationary night blindness, or other conditions of the retinal problems which are causing nystagmus particularly. So whenever you have that, you do look into a paradoxic pupillary reaction. Now what is that? Paradoxic pupillary reaction is a condition in which the pupil is in the light, it is dilating. So this is because of a delayed reaction, and now it is known it is a melanocytic pathway which is there. In addition to the rods and cones that we have, there are melanoreceptors also in the retina, and in conditions like the cone rod dystrophy or CSNB, the cones are affected, but the melanocytes are still present in the normal percentage only, and they'll give rise to this paradoxic pupillary reaction. So that's another thing which one should keep in mind as a postgraduate, that you can keep about. I think the cases which Madam presented were very interesting. I think she highlighted the problem. In the second case, she mentioned the most common problem, as I was saying, that the ophthalmologist straight away dilate the pupil. And that case was missed because of that. And when Madam asked him to come again and saw, that could be picked up as a schwannoma. So that is something which we should always do. Always examine the pupils, note down before you start dilating. In the pupillary sparing cases in third nerve palsies, case 1, the interesting thing which I would like you to remember is see for the asymmetry. If the asymmetry is complete, like total involvement is there, of course it is fine that this will be a pupillary involvement. Whenever there is a little involvement, you wait for time. And if there is no pupillary involvement initially, you should wait for 5 days before you send the patient off, thinking that it is just an ischemic lesion. Always call him back on the 5th day and see if there is an involvement. You may catch up an aneurysm, as ma'am did see. So that should always be kept in mind, especially if there is a partial third nerve palsy. So in a partial third nerve palsy, the involvement of a pupil which is not there may come up in 4 or 5 days. If it's a complete third nerve palsy and no pupillary involvement, then the case is going to be much simpler. So imaging would have to be done in a case if you have a partial third nerve palsy. Call him again on the 5th day. And sometimes even the lumbar puncture may have to be done. So the third case also was very nice, in which the third and fourth nerve involvement was seen in the cavernous sinus. So I think it's been a very nice talk on the pupils, and I'm sure the postgraduates would make full advantage of this class and the series of lectures that I think the iFocus has organized. Rashmin and Dr. Santosh really need to be congratulated for having this series. And once again, I would like to congratulate Dr. Ambika for taking pains to highlight the problems of pupils.
Sir, there are a few questions regarding the cases.
Yes.
in the first case, MRI and MRA both were ordered. So is in every case, do we need to order MRA as well, or is just MRA sufficient?
You're asking about the pupil involving third nerve?
Yes, ma'am.
See, if there is a pupil involving third nerve, default ask for an angiogram. So ask for an MR angiogram, always rule out a PCOM aneurysm, which is the most common cause we do encounter in a pupil involving third nerve.
Ma'am, and Worth 4 test in the second case. This is the only thing which is written. I can't figure out what they have written.
Maybe you're asking the prism base out test. You're talking about the microtropia or what?
Ma'am, and the question is Worth 4 test in the second case.
There was no Worth 4 dot. I think they mistook it. It was a 4 prism base out. So that was a microtropia assessment.
Okay. Ma'am, and there is one more question. If they have in the third case, if they have used the steroids, then was there not a flare up because it was a TB?
See, he had a briefly around a 10 days course of steroids. So with the 10 days course, I don't think it's going to have flared up a TB and cause such huge lymph nodes to crop up within 2-3. I think I would have seen him in a couple of months, 2 to 3 months later I saw. So probably he had a TB which had resulted in a granulomatous inflammation. Probably he had a transient response to the steroid. But you see, always TB will behave like an inflammatory condition. It will have a transient response. But the moment you come down, it will again relapse. So that's a very classical nature. And that's the reason why you find it difficult to differentiate a TB versus a sarcoid in many entities, because both are going to cause a picture which is quite similar. But this guy, being a medical profession, he had a lymph node biopsy, which has proven that it is granulomatous inflammation, and he had a TB which was positive in his blood workup, which we don't see that frequently. But only thing is, like making a diagnosis of TB, we have to be very skeptical. Make a diagnosis after a ID clearance, start an NTT, because most of the times an incomplete course of antituberculous drug therapy is something which it's not surprising for us to see in our practice, because there are people who have come up to us with like 3 drugs for 4 months, 6 months. I mean, like that's not the type of therapy what you are supposed to give. If you have made a diagnosis of TB, complete the course of antituberculous treatment, and it should not be a irregular treatment like this, which is not surprisingly we see in many cases coming to us. So always that guy probably would have responded if we started the steroids with a cover of an antituberculous treatment in the beginning itself.
So what's your take on that, sir? Steroids?
I think the corollary of what that case, I think, should be remembered, that one should not be using steroids so easily or superficially. It has to be kept in mind that one is the situation that it may be tuberculosis, which may flare up with time. So before you start steroids, you should be careful in your diagnosis. Many times steroids are not required. I'm sometimes surprised to see many of the cranial nerve palsies in which steroids are given very rampantly by ophthalmologists or by general practitioners. I would say that one should not be. It doesn't help in most of the situations, including in the non-arthritic ischemic optic neuropathy, which has now been shown that steroids do not really expedite the recovery. So we have to be careful in the use of steroids. It may cause more harm if he is a diabetic or if he is a tubercular patient. So one should be very careful in using steroids, except for Bell's palsy, in which I think steroids may be used. I would hardly consider, or maybe in the cases of Tolosa-Hunt syndrome, once we have made a diagnosis of a painful ophthalmoplegia, one should not be using steroids at all. I mean, that easily. Or it's condition like a demyelinating condition, then you may be using steroids. So once you have made a definite diagnosis, then only use steroids.
Dr. Rashmin, do you want to add something in this regarding the steroid use in?
No, I think Dr. Ambika Madam and Dr. Pradeep Sharma has covered the topic adequately well.
Yeah, thank you for patiently answering all the questions, ma'am. Sir, do you want, Dr. Rashmin, sir, do you want to add anything to the session?
No, I think
Abnormalities.
wonderful session, and whatever is required from a residence level or postgraduate level was covered in great detail, including a theoretical points that you might be asked in a full question in a short note, points that you might be asked in Viva, or cases that you might encounter in your exams. So everything, she covered it from all aspects, and congratulations, Dr. Ambika ma'am, and thank you so much for joining us. It was a great lecture. And thank you, Pradeep Sharma
Thank you,
sir.
sir.
Your presence always makes it, takes the whole level of discussion a notch higher. So thank you so much.
So
Thank you, sir. Thank you, Rashmin.
thanks a lot. Thank you
Good
for
night.
moderating, Asha. Wonderful job.
Thank
Nice
you.
to see you doing that. During the COVID days, she was the sheet anchor of holding the classes, and we really enjoyed that. So you are carrying up with that function. Very nice.
Thank you, sir. Very nice to hear this from you.
Yeah.
Good job, Asha.
Thank you, ma'am.
Good night, all. Bye.
Thank you, Rashmin, once again. Thank you, Santosh.